pressure. Previously it was taken cutoff as 25 mmHg. Now after 2022 and 2018 symposium, they have decided that PAP would be taken as 20 mmHg. And PVR, which was previously as 3 Woods unit, now it has been recommended to 2 Woods unit. The reason for doing that is that they have included CTEPH, that is chronic thromboembolic pulmonary disease, as a phenomenon now. And in that disease they include this spectrum also, so that the screening occurs earlier. Previously we used to wait till 25 mmHg, previously we used to wait till 3 Woods unit. Now they have decreased that criteria, like we keep on changing the criteria for systolic hypertension also. So they have decreased this criteria for early screening. Classification we already discussed. Class 4 is the CTEPH. These are the other classes. Class 2 being the heart related causes. Class 3 would be the lung related causes. 1 is idiopathic and 5 is pretty rare. All the hematologic disorders in it. So it is often underdiagnosed because to diagnose it perfectly we need to undergo a right heart catheterization, and which is difficult to convince for a patient, and it needs a regular follow-up also.
In our setup, when we find any patient who has dyspnea on exertion which is not explained by any means,
Yes.
it is not explained by any means, then
Exactly.
and still patient is
Willing also to go
yeah.
ahead for the treatment. Yes. So first focus is always doing the chest X-ray, the primary investigative chest X-ray, ECG, echo finding. Whatever we miss on X-ray and ECG is definitely picked up on echo finding. Like sir also suggested the right volume overload and hypertrophy part. So we need to rule out why right ventricular hypertrophy is occurring, why there is rise in pH, if the X-ray is normal, and what are the other changes that we discuss in the echo part. If those are present and there is no other cause that we can find out, we should definitely refer for a CTEPH center, or there are other centers for pulmonary hypertension, or setup where there is a backup of cardiac and stimulation, so that we can go for a ventilation perfusion scan and further diagnosis. So nowadays it is not historically fatal, it is potentially curable. Early recognition. So definition we discussed. So the other part of the inclusion in the definition is the normal capillary wedge pressure. Capillary wedge pressure is normal. Again, this finding is found in the right heart catheterization. Capillary wedge pressure is the indirect measure of LA pressure, left atrial pressure. So usually in the group 4 classification, the LA pressure would be normal. That means that disease is purely due to the vascular resistance that is occurring. There is no component of heart or other LA or mitral valve included in this. So that is particularly for the CTEPH patients.
You said pulmonary resistance is also detected by right heart catheterization.
Yes, sir. Sir, PVR is a finding that we deduced from pulmonary capillary wedge pressure. Pen sketch pen.
Markers.
Continue with your background. Data is continuous.
So basically the pulmonary vasculature is between the right ventricle and the left atrium. Right? From the right ventricle there is output of pulmonary arteries, and then after that there is pulmonary vasculature, and then there is the pulmonary veins, and the LA appendage and LA comes into picture. So pulmonary vascular resistance is the area of the pulmonary vasculature, the resistance caused by the pulmonary vasculature. So how we calculate that? It is the right ventricular outflow, that is pulmonary arterial pressure, minus the LA pressure divided by the cardiac outflow. So that gives you value of the pulmonary vascular resistance. So these are the lungs. Right ventricle giving pulmonary arteries, right and left pulmonary arteries. Then it divides into segments. subsegmental branches. So pulmonary vascular resistance (PVR). PVR is basically this part, and after that pulmonary venules and LA appendage, everything comes into picture. So for calculating PVR, we subtract this thing, PAP, pulmonary artery pressure, minus this LA appendage or LA pressure, which is also called as pulmonary capillary wedge pressure, divided by the cardiac output. That gives you the pulmonary vascular resistance. So this finding we deduce after right heart catheterization.
It should be less than 2.
Yes,
It's normal.
1. Normal is 1. So to be on a safer side, they have taken as a 2 value, and that is calculated as a Woods per minute. The other calculation is 9 seconds per centimeter something raised to 5.
How to convert in millimeter of mercury?
So history of acute P that is present, which is not resolved. Symptoms we already see. These are the symptoms. And there is one WHO functional classification. It is quite similar to NIHA classification. ECG changes, X-ray changes that we discussed. Echo findings that we discussed. This is the criteria which shows that the probability of developing PH. It is based on the peak tricuspid regurgitation velocity. Pathophysiology we already discussed. These are the probable causes: splenectomy, inflammatory disease, history of P, that lead to finally the CTEPH. It is basically an inflammatory and proliferatory disease of the pulmonary vasculature. Thrombosis occurring, changes, flattening of the septum. Diagnosis: CTP. Previously CTPA was used, but nowadays BQ scan, it is more sensitive. If BQ scan is negative, then the probability of having CTEPH is minimal.
I don't think the scan is being done in Baroda.
That's Zydus.
કોઈ જગ્યાએ કર્યું નથી ને આપણી નથી ખાલી થિયરીમાં જોઈએ.
ના સર, આપણે ત્યાં અમદાવાદમાં તો થાય જ છે, ઝાયડસ અમદાવાદવાળીમાં તો થાય જ છે.
ભાઈલાલવાળા નથી ને?
એકચ્યુઅલી મેં સર નેટ પર સર્ચ કર્યું હતું, 2-3 ઇમેજિંગ સેન્ટર છે એમાં થાય છે, અને કોસ્ટ ઇઝ ઓલ્સો 6,000 to 8,000 મળીએ, એવું કંઈક વધારે નહીં. હમણાં અહીંયા મેં એટલે આવતા પહેલાં લાસ્ટ વીક મેં બી કદાચ ચેક કર્યું થાય છે.
કયા હતા સેન્ટર?
છે પ્રાઇવેટ સેન્ટર જ છે, પણ છે થાય છે.
વેરી અનલાઇકલી, કારણ કે લોડ એટલો ના હોય તો
So BQ findings we saw normal picture in that area when there is CTEPH, there's underfilling, perfusion mismatch we call it. Then CTPA findings, narrowing of the pulmonary arteries, segmental arteries, sudden narrowing. Survival dependent on the mean pulmonary artery pressure. As much as low that you can bring it, it increases the survival. Treatment modalities: endophthalmectomy discussed, balloon pulmonary angioplastics. BPA was abandoned previously. Now it has again got some more interest because some of the Japanese people have produced some good results with BPA, with the smaller size of catheter. They had formulated this thing formula for increasing the pressure also. So nowadays it has picked up. Then riociguat, it is the only FDA approved drug for CTEPH, but there are other drugs that are coming. We will see about them. Challenges we discussed: there is a lot of collateral flow, isolation is required, dissection plane, involved vessels. We discussed this part. We have to undergo a circulatory arrest and empty out the whole flow. Goals are to reduce the PA pressure and decrease the remodeling. These are the plaques that we can get out of the endophthalmectomy. Mortality is due to pulmonary edema, reperfusion. Multi-organ system failure is due to not selecting the right patient. Maybe if we select them earlier before optimization, that leads to kidney failure and other organ dysfunctions. Survival after PEA, it increases up to 8 to 10 years are when the pH is more than the obstructive disease. When you are not able to find adequate pulmonary arteries that are blocked, the pH is more towards the idiopathic, then it is useless to do PE. And if there is decompensated liver failure and everything, distal disease, endarterectomy is not possible for the distal disease. It should be segmental or the primary branches. Age is a relative contraindication. Rheosiguate. And rheosiguate, first for understanding the rheosiguate, we need to know what is soluble guanyl cyclase. Soluble guanyl cyclase, SGC, is a receptor for producing a cyclic GMP. Now, cyclic GMP is a protein that helps in pulmonary vasodilation. So, SGC is dependent upon nitric oxide. So, what rheosiguate does, it is making SGC independent of nitric oxide. It does not require nitric oxide to produce cyclic GMP. So, once if rheosiguate binds with the SGP, it can produce cyclic GMP to the maximum level even if NO is present or not. It does not need nitric oxide. This mechanism depends on the pathology that in pulmonary hypertension, the production of nitric oxide decreases in the body. I will show you in this thing further diagram. So primarily the action is that rheosiguate makes it independent of the nitric oxide mechanism.
That is why sildenafil is adopted.
Sildenafil, sir, it is a PDE5 inhibitor, that is phosphodiesterase 5 inhibitor. It is also used for this mechanism, but it acts more on the type 2 and type 3 part of pulmonary hypertension, not on the CTEPH. But they are also, increasing that studies so that they can include one more drug in the type 4 part, because we have only one drug. So they are figuring out other pathways. So we will discuss in the further slides.
This molecule is similar to versicolin. That is for cardiac.
Valsartan.
No.
Where are C gone?
Okay.
This molecule is similar to,
Yes.
Heart failure.
heart failure.
Yes. So contraindications are AKI or maybe the creatine clearance of less than 15 ml per minute. Those receiving dialysis and liver disease, pulmonary veno-occlusive disease, not the artery part, the vein part, the pulmonary veins. If those are occlusive, then the rheosiguate is not helpful there. Pregnancy, it is not recommended. Dose is 0.5 mg TDS to maximum 2.5 mg TDS. We need to titrate the dose to detect whether it is causing systolic hypertension or not, because it causes systolic hypertension. So we need to titrate the dose accordingly.
How will you calculate PVR in pulmonary veno-occlusive disease? Or how in general it is diagnosed?
Sir, if the pulmonary artery, CTEPH, we are not finding major pulmonary vessels that are occluded, pulmonary arterial vessels, because it measures the CTEPH measures the pulmonary artery vasculature. If that comes out to be normal, we can figure out it could be because of veno-occlusive disease.
So is there any protocol to check the veins also, pulmonary veins? Because in that particular condition, your Swanken's catheter will also not give you the PVR, because એની વચ્ચે તમારી capillary vein pressure વચ્ચે તો block આવી ગયા.
Yes. So probably this would be, it would be a diagnosis of exclusive vein. So this is the pathway of nitric oxide. So we can see in pulmonary hypertension, the endogenous nitric oxide decreases. There is unavailability of nitric oxide expression. So its expression also decreases. There is uncoupling occurring. I just forgot this full form of ADMA. Probably it is a protein that converts L-arginine into citrulline. Basically, the mechanism is that the nitric oxide is not produced in the endothelial cell when the patient is having pulmonary hypertension. So what SGC stimulator, that is rheosiguate, does is it acts on SGC receptors, and nitric oxide, even if it is not present, it will help in producing cyclic GMP, and cyclic GMP further goes to protein kinase G and leads to vasorelaxation and remodeling.
So it bypasses nitric oxide pathway. In a way, it bypasses the nitric oxide.
Yes, exactly. And even if nitric oxide, whatever little amount is present, it will only augment the action of eosinophil and produce more cyclic GMP. Sir, so what you were saying is that sildenafil, that is PDE5 inhibitor, that helps in this pathway. PDE5 enzyme converts cyclic GMP into GMP in active form. So this inhibitor lets the accumulation of cGMP and that leads to protein kinase G and this thing. So there are further drugs that are developing on this pathway also, protein kinase G. The newer drugs that are upcoming, they are acting on this protein kinase G pathway, but not much importance is given to them because it is basically a terminal pathway. We need to figure out drugs which are more acting on the upper pathway and find out other pathways of causing vasodilatation. So these are probably some drugs that are available. Phosphodiesterase 5 inhibitor that acts on PDE5, sildenafil, tadalafil, interferon receptor antagonist. They are ambrisentan, bosentan, macitentan. Newer researchers are coming up with macitentan part. Prostacyclin analogs, ecoprostacyclin and this thing, iloprost. Those CTEPH, for CTEPH, riociguat is the approved choice in the FDA. But they are searching for these three areas also, and out of which macitentan has approved to be promising. So this is a chart this was study published by the Japanese people when they developed that BPA, and BPA part again got the importance. They found out that patients who had BPA plus medical therapy, they had more stable course in the time. This is the timeline and this is the survival probability. So they saw that the patient receiving MT, that is medical therapy plus this thing, BPA, had a more longer lifespan and even better than the pulmonary endarterectomy. So this study was taken in those patients who were not considered a good case for PEA. So that's why this picture shows. The middle picture is only the middle medical therapy.
So without therapy, their life expectancy would be very less.
Yes.
Very less. કારણ કે આ ટ્રાયલ બી તમારો 2 વર્ષ નો હતો.
Yes. And even after pulmonary endarterectomy, we have to give lifelong anticoagulation, and again that if there is residual pH on repeated RHCs, if we found residual pH, then riociguat should be given again.
You have to combine both
Yes, multimodality is required. It is must. So just rough guidelines. Surgical part acts only in this area. That is the major pulmonary artery, right and left part, and the subsegmental part. Not beyond only the segmental part. Sorry. Then the segmental plus subsegmental area is covered by the BPA, and medical therapy actually targets at the distal part, more microvasculature there. This is the action of these drugs. So diagnostic pathway, we receive mostly patient with exertional dyspnea. What we can do as a physician, medical history, physical exam, ECG, NT-proBNP, O2 saturations. If we find suspected cause to be lung disease, then the lung workup, PFT, VG, chest X-ray, chest PT. CPET is cardiopulmonary exercise testing. People have started doing this nowadays. This is basically applying a mask to your body, and then the patient is supposed to do a cycling or a running, and they check all the PFT parameters. That mask checks all the PFT parameters. Your tidal volume, your vital capacity is already being checked through the monitor, and while you are doing exercise.
So main parameter they check is VO2 max.
Yes. Then there is a pH to check for cardiac disease, echo and CPET. Probability of pH, if we find it is present, then we have to manage accordingly. Is it a lung disease, or if it is a cardiac disease, or if the diagnosis is not found, then we have to refer for a higher stricter. After referring, if there is pH of unknown origin, then we perform a lung VQ scan. It is normal, then CTEPH is excluded. And if there is unmatched or mismatched defect, then go for pulmonary angiography or CT or MRI angiography. Then the workup of CTEPH is complete. After after finding what is patient is having CTEPH, we have to evaluate it is operable or inoperable. Operable criteria, if it is favorable, that is probably a center would only decide it is favorable for surgery or not. Then if it is required, then we go for that. The target goal is achieved or not achieved, then we go for a BPA. BPA, then if the part is achieved, then we have to go for vasodilator therapy. That also includes calcium channel blockers. Inoperable, then again the same pathway, BPA and vasodilator therapy. After diagnosis and treatment, lifelong anticoagulation, operability assessment. Okay, this is again the same slide. Technically operable or not, risk-benefit ratio, targeted medical therapy. Different classifications and their prevalence and their therapeutic strategies. Here, class 4, these are the therapeutic strategies, class 1, 2 and 3. So more of the drug part is present in all the 5 classes. Only the surgical part is in CTEPH. Patient with history of PE plus persistent symptoms. This is again the same slide. Perform VQ scan and VQ mismatch defect and send for CTPA, right heart cath. Evaluate suitability, curative, inoperable. If inoperable, then BPA and medical therapy. Residual pH, again BPA and medical therapy. So it is something in which medical therapy has been throughout, even before diagnosis, PDE5 inhibitors are used. So challenges and future directions that are there for coming 5 years. There are need to develop assessment of microvascular disease, like you said, sir, veno-occlusive disease. Maybe that would be the part of it. So dual energy CT scans are coming up. Advanced MRI which detect assessment of RV function without use of dye and radiation. Newer targeted therapy to find out more pathways of action of the vasorelaxation part. So for that, TGF beta pathway has been found, which is promising, and the drug is sotatercept. Prostacyclin pathway, newer drug is CTEPH, and ERA pathway macitentan. I will show you the pathway of TGF. This is the pathway for TGF. TGF is a tumor growth factor beta superfamily. So these are the proliferative agents. These are the anti-proliferative agents. DMPR2 pathway and activin-like kinase 1, 2, 3, 6. These pathways are anti-proliferative, and these are the proliferative pathways. So if these proliferative pathways, both of them exist in our normal cell, but proliferative pathway leads to proliferation of the endothelial cells, leading to more vascular diseases. So if we inhibit this pathway, that is this drug, it will lead to more anti-proliferative measures, the activation of this protein pathway. So this is the mechanism of the drug. Then there is endothelin pathway, macitentan, ambrisentan, bosentan, nitric oxide pathways, and then there is PDE5 pathway, then the prostaglandin. And this CTEPH is the newer drug that is coming. So this is a summary. It is no longer a hopeless disease, and improvements are going on. Primary treatment modalities are the same, but nowadays Riociguat is getting support from other drugs. That it's in the trial phase only, but within 5 years they will be coming in the market. VQ scan, advanced imaging, and ongoing advances are to find out more pathways to find this thing, distal vasculature diseases.
What is the prognosis without intervention?